All right, today we're going to start our circulatory unit with the heart. So first we're going to talk about kind of where the heart is in the body, where does it sit, and the orientation, how do we talk about the heart, the coverings of the heart. This will be very familiar to us, the different layers of the heart. So we've talked about different layers of the skeletal muscle, the nerves, so very similar in the heart as well. And then we'll go through the different parts of the heart, the valves and the chambers. We'll talk about all the vessels in another lecture. And then we're going to talk quite a bit about the muscle tissue, the cardiac muscle tissue. It's similar to skeletal muscle tissue, but it does have some very distinct differences, and we'll talk about those. And then innervation of the heart, what causes the heart to pump? So, you see in the movies where they rip the heart out of a body and it keeps pumping in your hand. How does that happen? It's not too far from the truth, surprisingly enough. And then we'll go through a little bit of disorders and development at the end. So the heart, it's a double pump. So it's just one big muscle, right? And so it's pumping simultaneously the right and the left sides of the heart. So you can think of it like two pumps, but they're pumping simultaneously. And the why we have two sides of the heart is because we actually have two circuits, okay? And so where those circuits cross are in the lungs and in the body, the systemic body, okay? So all the tissues in the body. So our first circuit is called the pulmonary circuit. So if we get our little laser pointer here, and we can follow the pulmonary circuit, and we've talked about, blood coming back to the heart. It's all going to come back to the right side of the heart. So the right side of the heart has a lot to do with the pulmonary circuit, okay? So it's going to receive all that oxygen poor blood from the body, and it's going to pump it out to the lungs, okay? So it's going to pump it out to the lungs where it can get reoxygenated out in the lung capillaries, and then it's going to return to the left side of the heart. So then we have our systemic circuit. Okay, so then the systemic circuit is going to be receiving this great oxygenated blood out or from the lungs and pump it out into the system. So all the tissues of the body are going to receive this oxygen-rich, nutrient-rich blood. Okay, and then that's where it's going to switch. Okay, so out in the system, then it's going to switch to the pulmonary circuit. Okay. So we have two different types of chambers in the heart. So we'll talk a little bit more about these individually, but essentially we have the top two chambers of the heart are the atria, and they're the receiving chambers of the heart. So they're going to receive blood from the body or receive blood from the lungs. And then the ventricles are really what is doing the work, and that is the pump. So the ventricles are going to be what is pumping the blood out to the lungs and out to the body. So let's talk about the heart itself and how we talk about it. So the orientation within the thorax, we know it lives between the lungs. And a human heart, a healthy human heart is not very large. It's about the size of your fist, less than a pound. So it's about the size of your fist, and that's not that large for the job that it does. And so it lives in between the left and the right lung, but it tends to sit a little bit more into the left lung. So it does sit a little bit left. So when you put your hand over your heart, you tend to put it over your left chest. So that is fairly accurate because that the heart does tend to sit over to the left. This area in the center of the heart is called center of the chest is called the mediastinum. And so it is the largest organ in the mediastinum. You have the thymus in there as well, and the trachea and the esophagus. So there are other structures in the mediastinum as well. So the orientation of the heart, so if you notice the point of the heart down here is called the apex, and it definitely points to the left. Okay, so it lies a little left of midline. And then when you talk about the top of the heart, it's called the base. Okay, so that's where all the vessels come out. And it seems a little counterintuitive that the top is called the base and the bottom is called the apex. But if you look, the apex it comes to a point. So that's what an apex means. It comes to a point. And usually it sits kind of in between rib 2 and 6, but again, you don't need to know that specific of a detail for it. Okay. So now let's talk about the heart coverings. So we've talked about the pericardium before, but we're going to talk a little bit more detail about the pericardium because we've actually got a few more layers than what we have said before. Okay, so there's two primary layers of the pericardium. So this outer, more fibrous layer is the fibrous pericardium. So if we look over, so we kind of blow up this, the pericardium here in this picture and take a look down here. So we've blown up this heart, wall of the heart, and this is how we get this picture over here. So this very outer layer is the fibrous pericardium, okay? So that's lots of fibrous connective tissue, very strong. It's what's connecting it to the diaphragm, to the vessels. So it is the fibrous pericardium, and it is attached to the parietal layer of the serous pericardium. So we've talked about the serous pericardium with the parietal and visceral layers of the pericardium. So that we just added that fibrous pericardium on top of or outside the parietal pericardium, okay? And so that is that parietal pericardium, and we also have the visceral pericardium that's right up against the heart wall, right? So the heart itself, and in between those parietal and visceral layers, we have the pericardial cavity, which is our serous cavity, full of serous fluid, right? So it allows the heart to pump without any sort of friction against the other organs in the thoracic cavity. So the visceral layer of the serous pericardium is the same as the epicardium. So here is the layers that we were talking about. We've had epi, myo, endo before, or epi, peri, endo. So very similar, to other structures we've talked about. So our epicardium is the outermost layer, okay? And it's the same thing as the visceral layer of the serous pericardium, okay? And then we have the actual muscle of the heart, and that's our myocardium. Okay, so that's where our cardiac muscle lives. And then the endocardium is just lining all the chambers of the heart. So that's the innermost layer. So here we have just written out for you what we have already discussed. So the epicardium is that outermost layer, but it's the same thing as the visceral layer of the pericardium. Myocardium is that cardiac muscle, and this lower picture just shows you how the muscle is arranged in the heart. It has these bundles, these muscle bundles, so it's just kind of interesting to see how it spirals around the atria in the top, and then it comes and spirals around those ventricles in the bottom. And then the endocardium is that innermost lining of the chambers of the heart. So now let's talk about the external markings of the heart. So if we take the heart and look at all those external structures, we've got some interesting things, and that it'll kind of tell us a little bit more about the internal structures as well. So if we look at the heart, here's our pictures of the heart. This is the anterior view. So that means we're looking at the anterior side of the heart, and then over on the right side, we're looking at the posterior part of the heart. Okay. So we have this coronary sulcus. So we have a few grooves essentially. The coronary sulcus comes around the entire top, the whole kind of almost at the base. So it's this whole groove, and it really separates the atria from the ventricles. Okay, so anything kind of above that coronary sulcus is going to be atria, and then anything below it is going to be ventricle. Okay. It's also where the coronary arteries run, so we'll talk about the coronary vessels, specifically those coronary arteries and cardiac veins. So if you're on the anterior side, you notice there's a groove coming down the front as well, and that is the anterior interventricular sulcus. So interventricular, meaning between the ventricles. So this delineates the right and left ventricle. So on this side, we have the right ventricle, and then on this side, we have the left ventricle. And if you notice, the left ventricle makes up the majority of that apex of the heart. Okay. And then same thing on the posterior side, we have a posterior interventricular sulcus. So again, this is going to separate the right ventricle over here and the left ventricle over here, making up that apex. So if we open up the heart, we can actually see these chambers. So this is a sagittal view of the heart, and we can see the different chambers. So we said the top is going to be our atria. So we have our right atrium and our left atrium, and they're going to be the ones receiving blood. Then we have our lower chambers or inferior chambers, and we have the right ventricle and the left ventricle. And so inside the heart, the right side and the left side don't cross. We don't want the blood in the right side of the heart to get into the left side and vice versa, because on the right side we have, low oxygenated blood, and on the left side we have highly oxygenated blood, and we don't want them to mix. So we have to have these divisions to separate all these chambers. Okay, so we have the interventricular septa. Okay, so that's just the wall that separates the two ventricles. And then underneath kind of this vessel here, we have the interatrial septa. Okay, so to separate the two atria. Okay. So let's go through the chambers individually and what kind of landmarks can we see with these chambers. So let's start with the right atrium. We always usually talk about the right side of the heart first when we're discussing the pathway of blood and all of that. We usually talk about the right side first. So in this picture, we're looking at the posterior view. And so we have our right atrium over here. Okay. So this is our right atrium. So it forms the border of that right side of the heart. It's going to receive that oxygen poor blood, okay, through a couple different vessels. Okay. So if you notice, there's a big hole here, and that is the inferior vena cava. So it's going to drain blood from the lower body. And then we have the superior vena cava up here that's going to drain blood from the superior or upper body. And then if you notice, there's one last spot that we drain blood from, because we have to drain the blood back from the heart as well, and that's the coronary sinus. So we drain blood directly back from the heart muscle itself, and it goes through that coronary sinus into the right atrium. So now if we look inside the atrium, the right atrium, we see some internal structures that are a little bit different, especially from the left atrium. So there's this ridge of muscles, okay, and it's called the pectinate muscles. So it's just this kind of ridge on the anterior side of the atrium, okay? And we don't find that in the left atrium, so it's a little bit special to the right atrium. And then at the bottom, kind of at the bottom of the pectinate muscles, there's a line or a groove, kind of a ridge, and it's called the crista terminalis. And essentially, it's where the veins enter the right atrium. So, especially the coronary sinus and the inferior vena cava. And I'll show you a picture of it in a minute, but essentially, it sits right about here. But I have a different picture for you for that one. And then in the middle of that interatrial septum, there is a little depression called the fossa ovalis. And essentially this is a fetal remnant structure. So we'll talk a bit more about the fetal circulation at the end of the lecture. And so it usually is a hole when it's a fetus, and then it closes and becomes this depression called the fossa ovalis in the adult heart. So we'll talk more about that in a minute. So here's a picture of a dissected real heart, and you can actually see some of these structures a little bit better. So here are those pectinate muscles, so kind of look a little bit like spaghetti. It looks a little bit more like the wall of the ventricle. So very different for the right atrium from the left atrium. And then right at the bottom of that, you see this kind of groove or ridge, and that is that crista terminalis. Okay. And you can see this opening to the coronary sinus. There's that fossa ovalis that we talked about that was a hole in the fetal heart, but now it's just a depression. So now let's move into the right ventricle. So we're following the pathway of blood. So the blood's going to return from the body into that right atrium, flow through into the right ventricle. So let's look at some of these structures. Okay. So it's going to go through a valve, and that valve is the tricuspid valve. So we'll talk about the valves in a little bit as well. And then the blood is going to pump out of the right ventricle through the pulmonary valve, through the pulmonary trunk, and out to the lungs. So we do see some special wall structures of the ventricle, and it's both in the right and left ventricles we see these structures. So if you notice, the wall is not smooth. Right, so those bumps and everything are called trabeculae carnae. So a little bit like those pectinate muscles up in the right atrium, it's just the wall of the heart is not smooth, it has ridges. And then we've got these other two structures that are associated with the valve itself. So that tricuspid valve has these little flaps or these little cusps, and essentially they're tethered down to the wall of the ventricle by these chordae tendineae that are these little cords, and they're attached to these papillary muscles. And the papillary muscles are these little ridges coming off the wall of the heart. Okay, so they tether them down. And it's essentially to keep that valve from prolapsing back up into the atrium when the blood flow goes out of the heart. So this is a big muscle down here, and it's going to pump all that blood out, these great vessels. And essentially we don't want it to come back up and into the atria, because we don't want it to backflow. So these valves are going to try to stop that blood from coming back up into the atria. But what happens if that valve just flips back open, right? That would be bad. So these chordae tendineae are going to tether them down so that it keeps that blood flow from going back up into the atria. So the left atrium is pretty unremarkable, okay? So it makes up kind of the posterior side of the heart, so kind of right up against the back of the thorax, okay? And it's going to receive the blood from the lungs. Okay, so we're going to go through these pulmonary veins, okay, to that left atrium. So nice oxygen-rich blood. And then that blood is going to flow through the mitral valve or bicuspid valve. So we had the tricuspid on the right, bicuspid on the left. So it's a very similar type of valve, and that is going to, the blood is going to flow from the left atrium to the left ventricle. So the left ventricle is the big horsepower of the heart. It's the biggest muscular part of the heart. It makes up the majority of the apex of the heart, and it has the same structures as the right side. So we see the trabeculae carnae on the wall, the papillary muscles tethering down those flaps, those cusps with the chordae tendineae. So very same structures as we see in the right ventricle in the left ventricle. Okay, and it's going to pump blood to the whole body, out that aorta, to all the arteries in the body to supply nicely oxygenated blood to all the tissues. And so that's why that left side is so much larger, because it has to pump all that blood to the entire body, whereas the right side just has to pump the blood to the lungs, which aren't that far away. They're right next door. So the left side has a lot bigger job, and so it needs a stronger muscle to pump all that blood out into the body. So if we look at the pathway that the blood flows through the heart, we've been kind of talking about it as we go, but I like this picture because it just shows you kind of how the blood switches from oxygenated to deoxygenated and how we flow through the body and through the heart. Okay, so let's take a little tour. So we're gonna start up here in the right side of the heart. Like I said, we normally talk about the right side first. So it's going to receive deoxygenated or oxygen poor blood from the body because the tissues have used up all the oxygen. They're sending the blood back to the heart. So that's going to go through the vena cava. So superior and inferior vena cava into that right atrium. Then that blood's going to flow through that tricuspid valve into the right ventricle. And the right ventricle is going to pump that blood out through the pulmonary valve to the pulmonary trunk, to the pulmonary arteries, and out to the lungs. So now we're in the lungs. Okay? So we go through the lung capillaries, and that's where that oxygen exchange is going to happen. So it's going to dump out the carbon dioxide, gain the oxygen, and now we become oxygen-rich blood. And so that oxygen-rich blood is going to come back to the left atrium via those pulmonary veins. Okay. And then the pulmonary veins are going to dump that oxygenated blood into the left atrium. It'll go through that bicuspid valve into the left ventricle. Okay. Here we're going. Left ventricle. And then that left ventricle is going to pump it out the aortic valve, through the aorta, and out to the system. So out to those capillaries in all of our tissues. And then our tissues are going to use up all of that oxygen, right? And then the cycle starts all over again. So now we're deoxygenated blood going back to the heart, and the cycle starts all over again. Now, two things to note, and we'll talk a lot more about vessels in our blood vessel lecture, but usually arteries contain oxygen-rich blood, right? That's what we usually think about. And veins usually contain oxygen-poor blood. But this is different. So in the pulmonary system, those pulmonary arteries that are leaving that right side are oxygen-poor. But you're saying, wait a minute, they're arteries. Yeah, but an artery only means it's going away from the heart, okay? So same, it returns via the pulmonary veins, and we say veins usually have oxygen poor blood, but these have oxygen rich blood. So we switch these guys in the pulmonary circuit, so it's a little bit different than our normal arteries and veins. So just pay attention to that, and we'll talk a lot more about it in other lectures as well. So we've talked a little bit about the heart valves already, but what are the valves made up of? Well, they have a connective tissue core called the cardiac skeleton, and we'll talk a little bit more about that later. And then the flaps of the valves, or the cusps of the valves, are made up of the endocardium. So remember that lining of the heart, and that's the endocardium, and that's going to continue to make up these cusps or these valves. Okay. So we have two different types of valves, the AV valves or atrioventricular valves, and that just means they're sitting in between the atria and the ventricles. Okay? So we have one on the right side and we have one on the left side. So tricuspid on the right, bicuspid on the left. And they're named for how many cusps or how many flaps they have in the valve. So tricuspid has 3 cusps and bicuspid has 2 cusps. And how we remember which side is which is we always talk about the right side before the left side. So you tri before you bi. So tricuspid on the right, bicuspid on the left. And then our other two types of valves are the semilunar valves. So these guys are named after the great vessels. So they sit in between the ventricles and the great vessels that are exiting the heart. Okay. So we have our aortic valve, which is going to sit in between that left ventricle and the aorta. And then we have our pulmonary valve that sits between the right ventricle and the pulmonary trunk, or pulmonary out to the pulmonary arteries. Okay. And these guys each have 3 cusps. They look very similar. So if we look down here, we kind of are looking at the top of the heart from the base. So the base of the heart, and you have your tricuspid with 3 flaps, bicuspid with 2, and then our 2 semilunar valves with 3 cusps each. And that's the actual view of the heart from a cadaver heart. So we touched base a little bit about the function of the valves. We don't want that blood to flow back into the atria. So the AV valves, that's their job, the tricuspid and bicuspid valves. So they are going to prevent the backflow up from the ventricles into the atria. So they are relaxed when the heart is, they're open when the heart is relaxed to allow that blood flow from the atria into the ventricles. But then when the ventricles contract, meaning they're pushing all that blood out to those great vessels, we don't want the blood to go back up into the atria. So if we look at this picture, right, so they're open when it's relaxed, then they close to keep that blood from flowing back up into the atria. They look like little parachutes, but that's why those chordae tendineae are so important, because it keeps those cusps or those valves from everting or flipping back up into the atria, allowing that blood back up into the atria. We don't want that to happen. And that can be a big problem in the bicuspid valve. We do see some disorders. You've heard of maybe mitral valve prolapse, and that's what happens, is that this does not function correctly, allowing some blood flow back up into the atrium, and it overloads the heart, and it eventually leads to heart failure. So very similarly to the AV valves, the semilunar valves have a function as well of stopping blood flowing back from the great vessels into the ventricles instead of into the atria. And it's opposite for when they're open and when they're closed. So when the heart is relaxed, they're actually closed to prevent that backflow from those great vessels into the ventricles. Okay. But when the heart contracts and it pushes the blood out, it's going to open those valves. So it flows right past them to get into the great vessels, and then as soon as the heart relaxes, that blood is going to want to naturally flow backwards, but it's going to stop that blood flow from flowing back into the heart. Okay. So they're opposite in terms of when they're relaxed and when they're closed, or when they're open and when they're closed. Okay. but they do very similar functions by preventing backflow of blood. So we'll touch a little bit on the cardiac skeleton. I'm not as worried about it, but essentially this cardiac skeleton acts like an anchor point for the muscle and for the valves. So it's this dense connective tissue, and essentially, so anything white here is considered the cardiac skeleton. So these are our 4 valves, so our 2 AV valves, tricuspid and bicuspid, for 3 flaps and 2 flaps. And then we have our semilunar valves, the aortic and the pulmonary valves. Okay. And so essentially it just gives those valves structure. It keeps them from over dilating or overextending. Those muscles all attach there as well to the skeleton, as well as it helps to prevent some spread of electrical impulses. And that'll make more sense when we talk about how the electrical impulses flow naturally through the heart and how it stimulates the heart to pump. So have you ever wondered what is actually making the heart sounds? So everybody knows the sound a heart makes, right? The lub-dub. And we know that the heart is a pump, right? So how does the heart pump? Well, the left and the right sides pump together. So the atria are going to contract to kind of help squeeze the blood from the atria into the ventricles, and then the ventricles contract, okay? So what is actually making that lub-dub sound? Well, the first sound, the lub, is actually the sound of the AV valves closing. Okay? So we know that they close when the ventricles contract, right? And then the second sound is the dub, and that is the semilunar valves closing. So we know after the heart contracts and it relaxes that those semilunar valves are going to slam shut. So essentially, if you think about it, it's like 2 doors slamming shut at the same time to make the lub, and then another 2 doors slamming shut at the same time to make the dub. So AV valves slamming shut together, and then the semilunar valves slamming shut together. Okay? So that makes our lub-dub sounds, and it's the valves. A lot of people think it's the heart physically contracting, but it's not. It's the valves closing. Okay? I want you to know that. You don't need to know these different areas to listen to the heart, but essentially there's different areas on the thorax to be able to hear the different valves. And this is really only important to hear for pathology over those areas. So if there is some backflow, you can get some heart murmurs. And the heart murmurs is just the sound of blood flowing where it's not supposed to be flowing. So you can listen over these different areas to listen to the different valves more specifically to look for pathology. So now we know the heart sounds are because of the valves closing, the AV valves and the semilunar valves closing all together. But there is another thing we talk about with the heart, and it's the heart cycle. So we talk about systole and diastole. Okay, and I have a great video about the cardiac cycle. So please copy and paste this URL so that you can watch this very short little video to show you a little bit more about systole and diastole. But essentially, systole is the cycle of the heart when the ventricles are contracting. So when the ventricles contract and push the blood out of the heart, that's systole. And then diastole is when the ventricles relax and they fill with blood because the blood is flowing from the atria into the ventricles when the heart is relaxed. And then right at the end of diastole, you get a little atrial contraction. They contract a little bit to kind of finish off and push that blood, the rest of the blood from the atria into the ventricles. So that is systole and diastole, and that's really all we'll talk about with the cardiac cycle, but please watch that video and hopefully it'll make a little more sense. Okay? So we touched on this a little bit earlier as well, and that is the difference in the thickness of the walls of the ventricles. So the muscle of the left ventricle is quite a bit larger than the right ventricle. And this is because it has to pump all that blood out to the body. So I've just written it down here a little bit more for you guys to show you. Also, this picture I like because it's more three-dimensional. You can get an idea of how thick that wall is on the left side compared to the right side. So it even compresses the right side into kind of a semilunar shape instead of a nice round structure like the left ventricle. So because there's so much more resistance in the systemic circuit out in the body, the left side has to work a lot harder to pump all that blood out into the body. So essentially, that left side is 3 times thicker than the wall of the right ventricle. Okay, so it kind of flattens that right ventricle a little bit because the left side is so large. So now let's talk about that cardiac muscle tissue. So it's very similar to our skeletal muscle, but we've got a couple differences. So it contracts very similarly. So it uses that sliding filament mechanism. If we remember way back to that, where the actin and myosin filaments slide across each other to shorten that sarcomere. I know, way back when, right? But what are the differences, right? So cardiac muscle, essentially it's branching. So one muscle cell branches and it can connect up to multiple different cells. So essentially, instead of just one long cell like the skeletal muscle, these guys are going to branch and they're going to connect up to other cells, okay? So, and these are individual cells, unlike the skeletal muscle, which is, multiple fused cells all together and we get multiple nuclei. So we have a lot of mitochondria in these cells as well. So if we look down here at this electron microscopy slide, we see the big nucleus here, and you can actually see these sarcomeres up end to end, all lined up, just like, we've talked about in our skeletal muscle. And then we see all of these mitochondria. So these guys here are all mitochondria. So lots of energy. Your heart can't take a break, right? It has to continue pumping and contracting all the time. So it's not like our skeletal muscle where, it's going to have times of contraction and times of rest, okay? So where these cells connect are called those intercalated discs. Okay, so these intercalated discs are where the cells come together, and it's a very complex cell junction. And then you get a network of multiple cells linked together. So let's look at a little closer at that intercalated disc or this cell junction. So they're interlocked kind of like an egg crate. So it has this ridged appearance, okay? And essentially this allows them to increase the surface area between the cells, okay? And when it's branched, it allows them to connect up multiple cells at the same time. So we want multiple cells communicating with each other so that they can all contract simultaneously. And the contraction mechanism is very similar to our skeletal muscle cells. So we've already talked about the sliding filament mechanism. So if you see here, these guys have the sarcoplasmic reticulum as well, which houses that calcium ion, and that's released and it diffuses into those sarcomeres, into the cell, and causing those actin and myosin filaments to shorten their or increase their overlap. So it shortens that sarcomere, if we remember way back to skeletal muscle. So the other kind of special thing about cardiac muscle tissue, cardiac tissue, is the conducting system of the tissue. So it's very different that way from skeletal muscle, because it's able to, a lot of these cells are able to contract just kind of on their own in a rhythmic manner. So what happens is something has to set the system off, the conducting system off. So there's a series of these specialized cells that are going to stimulate the other cells to contract. And it all starts with the sinoatrial node, or the SA node. And the SA node sits up in the right atrium, right at the top, and it is the pacemaker of the heart, the kind of natural pacemaker of the heart. So not all of the cardiac cells are innervated. So they can all kind of contract rhythmically without innervation. So some of them get stimulated, but all the other ones are just going to all contract together. Because remember, we talked about the branching, they're all interconnected, and that's how we get this rhythmic heartbeat. So all cardiac muscle tissue has this intrinsic ability to generate and conduct impulses. So they can all work together, and the cells can contract all together and create this rhythmic heartbeat. So if we look at the pathway of this conducting system, we're going to start in the SA node. That's our natural pacemaker of the heart. So the SA node generates that very first signal, okay? And then it's going to disperse out through that right atrium, even over to the left atrium. But what happens is it's going to then stimulate the AV node, okay? So AV, very similar to AV valve, right? The atrioventricular node. So it's going to pause kind of right before it hits the AV node, because it has to cross that atrium. Okay. So then once it stimulates that AV node, then that AV node is going to go down this bundle down the interventricular septum. Okay. So this AV bundle is then going to throw off a bunch of branches. And they're just called bundle branches. Okay. So specifically out to the left and the right ventricle. Okay. And then those are going to branch into these little conducting networks. So it's a smaller network, and these are all in underneath the endocardium. Okay. And these guys are called Purkinje fibers. Okay, so the Purkinje fibers are what are going to go out into all those different cells in the myocardium. Okay. And essentially the whole point is that the signal is going to start up at the SA node, up at the top, okay? So, and then it's going to, the atria are going to contract together to kind of finish off that, pushing the blood into the ventricles. But then it has to take, the AV valve has to get it all the way to the bottom of the heart, and essentially it stimulates the bottom of the heart up. So it contracts kind of apex upward. So that makes sense, because you'd want to push the blood from the bottom of the heart out towards the top, right? Towards those great vessels. So that is how we get that signal happening through these AV branches, these bundle branches out to the Purkinje fibers. So it essentially stimulates the apex first and then all the way up the wall, so that it pushes all that blood out of the heart. Now we do have overarching control from the central nervous system, so the heart isn't just pumping all on its own. It is getting controlled via the autonomic nervous system. Okay. So we do have a cardiac center in the brain stem. So we talked a lot about the autonomic nervous system having some of these centers in the brain stem that are part of that reticular activation center. Okay. So we have our parasympathetic part of the autonomic nervous system and sympathetic. So we call the parasympathetic the cardioinhibitory center, and then the sympathetic the cardioacceleratory center, right? Because the parasympathetic slows down the heart, rest and digest, and then the sympathetic is going to speed up the heart and increase the heart. So this is how we alter our heart rate. So we kind of have an inherent rhythmicity, started by that SA node, but then if we need to increase or decrease the heart rate, it's all under the control of the autonomic nervous system. So the parasympathetic is going to come via the vagus nerve, and it's going to innervate. So here's our vagus nerve coming out of the brainstem, and it's going to come out and stimulate that SA node and AV node directly. Okay, so it'll decrease the heart rate just by stimulating those nodes. And then the sympathetic is going to travel down the spinal cord and then out our sympathetic chain ganglia. It's going to go up a little bit because we're not in the right area there. And then it's going to send out some fibers out to the SA and AV node, but also straight to the heart muscle itself. So it's a little bit different from the parasympathetic, so it also stimulates the musculature directly. So not only does it increase the heart rate for the fight or flight response, but it also strengthens the contraction. So it makes the heart contract even harder. So not only faster, but also harder. So now let's go through the blood supply directly to the heart itself. So it's this big muscle pumping all the time and it needs a lot of oxygen. So the coronary artery is just come right off the base of the heart, the base of the aorta, and just runs straight to the heart muscle itself. So if we follow where these coronary arteries go, we have our left coronary artery, okay? And it's going to come and it's going to give off that circumflex artery branch, and it's going to continue as the anterior interventricular artery. Okay. So it's also called the left anterior descending artery. So LAD is another clinical name for it. But I like the interventricular artery because it runs in that interventricular sulcus. So however you remember it, but I like interventricular artery best. And then the right coronary artery is going to branch and go around in the coronary sulcus, and it's going to give off this right marginal artery as a branch. Then it's going to continue down the back side of the heart and become that posterior interventricular artery. Or the posterior descending artery, or PDA, is another clinical name for it. But again, it runs in that posterior interventricular sulcus. So here's just a blow-up picture of what we were just talking about. Left coronary artery coming off, circumflex artery going around, and then that anterior interventricular artery. Then the right coronary artery going around, giving off that right marginal branch, then going back to that posterior interventricular artery. So now we have to get that used up deoxygenated blood back from the heart muscle to the right atrium. So the coronary veins are going to carry that deoxygenated blood. So the last exit is the coronary sinus. So the coronary sinus is what's going to dump straight into that right atrium. But we have to drain into that coronary sinus. So there are three major veins that are going to drain into the coronary sinus. On the anterior side, we have the great cardiac vein. It's going to come around and drain into the coronary sinus. On the back side, you have the middle cardiac vein. And then on this kind of right side, we have the small cardiac vein. Okay, so all three of these guys are all going to dump into the coronary sinus, which is just a little bit of an enlargement of the vessel, which is why we call it a sinus. We've seen a few other sinuses in the body. We've seen them in the brain. So it's just a pooling, a little larger pooling of blood right there in the coronary sinus before going into the right atrium. So this is just a blown up picture of those cardiac veins draining into the coronary sinus. So we do see some disorders of the heart, and specifically a lot of problems with those coronary arteries. So because the heart needs all that oxygen so much to pump all the time, if you have any sort of blockage in those coronary arteries, it can be very detrimental to that cardiac muscle tissue. So our broad category of this type of disease or disorder is coronary artery disease. But there are a couple different things that can be happening. So one term we use is atherosclerosis. So atherosclerosis is just the fatty deposit buildup kind of in and around the arteries. So that's just shown over here in the picture, where you can see these fat deposits in and around these arteries. And then specifically, you can get just chest pain, and that's angina pectoris. So chest pain from kind of this atherosclerotic buildup, where the tissues just get a little bit hypoxic, where they don't get enough oxygen and they become a little hypoxic, and you have some pain in that area. Now, a heart attack itself is actually called a myocardial infarction. So essentially, there's a blocked coronary artery directly. So when you talk about, chest pain and atherosclerosis, it's not a full blockage. So you get just kind of decreased blood flow. But a myocardial infarction is where you actually get a full blockage, and the tissue, the muscle tissue, becomes ischemic, meaning it starts dying, and you get some damage to that heart muscle. And the silent ischemia is the scary one, where you don't have any sort of pain or warning signs associated with it. You just get these other problems. So you just get the blockage and potentially death. And so there are some ways that, you can fix these things, and you can do an angioplasty, meaning you go into that coronary artery and put a stent in so it holds open the artery so that blood can flow more smoothly. But if you have a full blockage and that coronary artery is no longer functioning, that's where you can do a coronary artery bypass graft, or a CABG, they call it if you watch Grey's Anatomy. So they actually use a graft little artery, and they take a different spot off that aorta and connect it up with the coronary artery. So they bypass the blocked area, wherever that may be. And of course, risk factors for coronary artery disease include all of these things that you hear about, high blood pressure, high cholesterol, smoking, underlying disorders like diabetes, which usually goes with, obesity, inactivity, but also, it can be genetic as well. So you can have a family history of heart disease. So another disorder of the heart is heart failure. So heart attack has to do with the coronary arteries themselves and the blood supply to the heart, whereas heart failure has to do with the pumping system of the heart and the valves. So there's a progressive weakening of the heart, whatever that may be. And there's different types of heart failure. But essentially, you can no longer pump the blood around the body to meet the oxygen demands of your tissues. So therefore, you develop heart failure. So congestive heart failure is one type of heart failure where the heart enlarges. And so essentially, the larger the heart is, the less efficient it becomes. So it no longer can pump as well and pump that blood out to the body. So why that happens, there's a couple different reasons, but we talked about valve insufficiency. So if you get, leaking of that valve, then you're going to increase the volume of blood in the heart that the heart has to pump out every time. So if you keep increasing the amount of blood it has to pump, you're going to start dilating that heart and getting it bigger and bigger. Hypertension, right? Coronary artery disease, those guys are both going to cause some stress on the heart, and it's going to cause congestive heart failure over time. And there are a lot of unknown causes as well. Now, pulmonary arterial hypertension is a very specific type of heart failure. And the problem is not starting in the heart, but starting in the lungs. So essentially, you get increased resistance in the lungs due to some sort of chronic lung disease. Usually it's associated with smoking. So you have, the emphysema, things like that, that are causing the lungs not to function correctly, and the capillaries, the blood gets smaller in the lungs, so it increases the resistance, and the right side of the heart has to work harder. So essentially you get some backflow of blood into the right side of the heart, and then you have right-sided heart failure. So that is the problem with pulmonary hypertension. So some other disorders, and we didn't talk specifically about ECGs or the electrocardiograms, but essentially it's just showing that conductive pathway we've talked about through the heart, and you can look at how that conduction is happening. But essentially, you can get arrhythmias, meaning that there's not a normal rhythm of the heart. If most of us have probably seen some sort of normal EKG. You get the spike and then another spike, and it's in a rhythm, right? So that's the pumping of the heart, that systole, that ventricular contraction. So if you have an arrhythmia, that's going to not be normal, not a normal rhythm. Okay, so there's a couple different types of arrhythmias. And ventricular fibrillation is one, or VFib. So a lot of times you hear this, on the medical shows where the patient goes into VFib. And essentially what is happening is there's random firing in the ventricles. Okay, so it's not a normal firing, it's not in a rhythm. And essentially, you get a crippled conducting system. Okay, so here's our VFib here. So essentially, the ventricles are just kind of firing randomly. So the ventricles are not contracting normally because they're not getting their normal electrical impulse to the ventricles. And this is this can cause cardiac arrest, and this is when you would use the shock paddles, in the medical world, which is often displayed falsely on those medical shows, and you see the flat line, and then they shock them. Well, if it's flatlined, and shocking them is not going to actually do anything, because shocking the heart actually stops the heart. So if it's already stopped, that's not going to help. So what it's doing is it's trying to stop this random firing and allow the SA node to regain control of that pathway, of that electrical pathway. So this is when you would shock the heart in ventricular fibrillation. So another type of arrhythmia, and a little more common and not as life-threatening, is atrial fibrillation, meaning the atria are kind of just randomly firing, and it's randomly stimulating that AV node. So some of it gets through, some of it doesn't. So essentially, instead of having this nice baseline very rhythmic, these other smaller peaks being rhythmic, you get this randomness of those peaks. And the ventricles are kind of responding normally, so you get kind of this normal contraction rhythm, which is different from your VFib. But what happens is the blood flow through the heart essentially is disrupted. So you get kind of this weird circulating of blood in the atria. Some of it gets through to the ventricles, and essentially what happens is you can form clots, which can lead to strokes. So over time, this can be bad, and a lot of people have AFib, and you get some shortness of breath, palpitations, anxiety, fatigue due to this. So the oxygenation is not 100%, but it's not as life-threatening as ventricular fibrillation. So now let's finish up with a little bit of development of the heart, which is quite interesting. It kind of starts as a tube, and then it folds around on itself, very similar to the brain, how we talked about that, and it folded over on itself very similarly. But I do want you to know that the heart is the earliest functioning organ in the body. So, that's when you go in for the ultrasound and you can look for the heartbeat in the fetus. And it's very exciting because the heart does pump very early on. So that's day 22. That's very, very early in development, which is really exciting. But it makes sense, right? You have to start delivering the oxygen to the body and to the tissues that are developing. So the earliest heart chambers are unpaired. Essentially, it's just a tube of chambers from, tail to head or head to tail, however you want to talk about it. But this list is from tail to head, so bottom to top. So first you have the sinus venosus. So these are the chambers, the fetal chambers of the heart. And this will eventually become the right atrium. So you're saying, okay, the right atrium's up at the top of the heart, but this is at the tail of this tube. So that's where all this bending comes into play. So this will eventually become the right atrium, coronary sinus, that SA node, very important structures in the heart. And then you have the fetal atrium itself, and this part actually becomes, the majority of the atrium, both of them, the right and left atrium, okay? Whereas the sinus venosus is, mostly just the right atrial structures, whereas the whole atrium does become mostly, left atria, but then finishes off that right atria as well. And then you have the fetal ventricle. So the fetal ventricle, and again, you're saying now we're getting towards the top. So the fetal ventricle is towards the top, but that's at the bottom of the heart. So again, we're going to get this weird twisting happening. So this is essentially becomes the left ventricle. Okay. And then last but not least, at the top, we have the bulbous cordus. And so this makes sense. So the bulbous cordus becomes our great vessel, so our pulmonary trunk and part of that aorta, and a little bit of that right ventricle as well. Okay. So let's look at kind of how that development happens. So let's look at these pictures. And again, you don't need to know the details on the time or anything like that, except for that, it's the earliest organ to start functioning. So on that day 22, it starts to pump. But look at it, it's just a tube. And essentially it started as two tubes that fused together. So it's just this tubular structure. And you have these different structures within this little tube. Okay. So essentially, but remember, where is it stuck? It's stuck in the pericardium. So essentially it starts growing, but then it has to rotate around because it can't fit inside that pericardium. Okay. So essentially it starts, this ventricle starts to kind of move. Okay. And so then it starts switching. The atrium was at the bottom, the ventricle was at the top, and it starts making this S-shape pattern, okay? So and then it bends all the way around so that our ventricle is at the bottom, the atria are at the top, and that bulbous cordus stays kind of at the same area up at the top to become those great vessels and part of that right ventricle. So again, I just want you to be familiar with those 4 fetal chambers, and then just that it is the first organ to start functioning and beating. So we do have some congenital heart defects as well. So there are multiple ones, and essentially it goes back to about, month 2 of development. But essentially this is kind of where all these chambers are starting to develop, and you don't get the delineation between the chambers. So the most common one that happens all the time is ventricular septal defect. So essentially you have a hole in that interventricular septum. So you should have a nice wall separating your 2 ventricles, because we don't want the right and the left sides to mix. So we talked about these septum that are supposed to be separating these chambers. So essentially we don't get that separation, and so your right and your left sides are going to mix. So that means your nicely oxygenated blood is going to get mixed in with your deoxygenated blood. And so you're pumping out this kind of semi-inadequately oxygenated blood. So the ventricles have to work a lot harder to get this blood out to the body, and your tissues are not well oxygenated. Okay. And this happens about 1 in every 500 births. So that's fairly common if you think about it. Now, your heart generally functions fairly well through life as long as you kind of, have regular exercise to help, keep the strength of your heart up. Aerobic exercise helps to clear that atherosclerosis, those fatty deposits, to try to decrease your risk of coronary artery disease. But a couple things do just happen naturally with age, and one of that is that the heart valves, those cusps, start to thicken and harden. So essentially you can get some abnormal heart sounds, you can get some murmurs because you can hear that blood flowing through those valves. You can also get some valve insufficiency that way as well, which will lead to congested heart failure. You just have a decline in your sympathetic innervation. So essentially the sympathetic innervation is less efficient. So you don't get that increase in heart rate and strength of contraction of the heart. So they just can't, they're not going to be running away from any tigers so quickly. And you do get some fibrosis just in the cardiac muscle themselves. So the cardiac muscle gets replaced with fibrotic tissue, and this it messes with the electrical impulses in the heart. So you can get some arrhythmias. So that's kind of where that atrial fibrillation comes into play, can be common in older people, especially men over women. What a vet I used to work with found out he had atrial fibrillation. So he's being treated for that. But like I said, it's not as fatal as ventricular fibrillation, but it can be a normal age-related disorder. So here's our learning objectives for this lecture. If you want to go through those and make yourself a study guide with the PowerPoint. And then next time, we're going to kind of talk, I'm going to shorten down the blood chapter, but I do want to cover it a little bit and learn about our different blood cells. We had to push that back a little bit to rearrange our schedule, but now that we have plenty of time, I'm going to go ahead and cover the blood chapter as well, and we'll do our blood vessels, chapter 20. And then next week also is spring break, so yay! Hopefully you guys all stay safe. Come to my office hours Thursday at 2:30 if you have any questions. Until next time.